righty. Okay, I'm going to share my screen. I just have a couple of slides to go over the project, and then we'll move forward. All righty. Is everybody able to see that? Okay. All right, so this is going to be real quick. We're going to kind of buzz through this so we can get to the meat of the session. But if there are any questions in the meantime, please let me know. So we're going to give a little bit of overview of ECHO here. So first, what is ECHO? It stands for the Extensions for Community Healthcare Outcomes. And for those who aren't familiar, I describe it as a kind of a version of telemedicine, where telemedicine is your traditional provider to patient, right? One-to-one. Well, ECHO takes that and just expands it. It's your group of specialists on one end called the hub. So it can be an area of addiction, or in this case, QI. And then the spokes are typically primary care sites, and it can be docs, nurses, administrators, anybody that kind of touches care. Those are the spoke sites. Those are the learners. They're the ones who are getting trained and mentor in a specific a topic. So they call it a hub and spoke model. 4 core principles to ECHO: leveraging technology. Unfortunately, COVID has made us all leverage technology and use Zoom and things like that. So that's kind of a no-brainer now. We don't have to explain that anymore. The next one is shared best practices, and this is a big one. When we are on these ECHO sessions, we know we have the expert team. They're going to give their best practices on what they've done. We also want to hear what the spokes have done in their own setting. What are the best practices from the spoke sites? We can learn just as much from you guys as you can learn from us. So really want to share best practices both ways. Case-based learning. So this one is, our ECHO's a little bit different in how we're doing the cases, but traditionally cases are presented at each session in an ECHO, and they're really the driving force for the ECHO program. This one's going to be a little bit different, where the first half of the cohort, the 6 sessions, we're going to be mainly dealing with educational materials, didactics, going over kind of the basics of QI, getting everybody familiar. The back half of the sessions are going to be where we're going to ask the spoke sites to present your project ideas, QI ideas, whether you have one existing and you're giving us an update on it, or you're starting with something new. And so it's going to be a little bit different. But really, the back half of the sessions are going to be very important, because this is your opportunity to ask questions, get advice, knock around some ideas, not only with the hub team, the expert team, but also your colleagues at different locations. So it gives you an opportunity to do that. So it's a little bit different, but case-based learning is one of the principles. And then the last one is really kind of an internal to ECHO principle, where we use web-based databases to monitor outcomes, and that's a requirement from them. They have a specific system, and we have to catalog all our information there. So that one's kind of internal to us. This picture, we use it a lot. It's a great representation of what ECHO can do for different groups within the healthcare system. ECHO is designed for patients to get the right care, the right place at the right time. Oftentimes, especially in West Virginia, where access is limited, referral wait times are long, it's easier for them to keep the patient in primary care setting longer. ECHO aims to do that by hopefully getting new knowledge to the providers. They can treat more patients and build a community practice. Hopefully we'll do that around QI here during these 6 sessions. The community and the system level, those are the big ones, right? We want to reduce disparities, retain providers, keep patients local, and then increase access, quality, reduce costs, all those things we talk about pretty much ad nauseum every day around any topic, not just QI. But this is just a good representation of what the goals are for ECHO. Some tips and tricks for Zoom and ECHO. We just want to be mindful of time. Hopefully we can have good discussion and get everybody have a chance to speak if they want to. Please turn on your video if you can. I think we're ace in that point right now. So thank you for that. Thanks for everybody turning that on. No PHI. And I know that's going to be a little bit different for us because of what we're talking about around QI, but just a reminder, no PHI on the calls, especially because we're recording them. We talked about this earlier. Feel free to direct message me if there's any technical issues. Sometimes silence is a good thing, people are thinking. So if you see me not saying anything, waiting for people to talk, I'm not frozen. It's just because we're giving people a chance to think about what they want to say. And remember to mute and unmute as you're providing comments and things like that. Obviously, treat everyone with respect. This is a safe place to share ideas and opinions. And then most importantly, let's have fun. I don't take myself too seriously. So I apologize if I, joke around too much, but it's 5 o'clock. Everybody's probably exhausted. So let's try to at least have a good time while we're doing this. Okay, and this just to give you guys a reminder, you probably have this information already, but just a breakdown of what the sessions are going to look like. We've got intro to QI today. We got a walkthrough and it with a Q&A the next time, and then initial QI process and steps. The big weeks are weeks 4 and 5. That's where we want Northwood and community care to present their ideas. So we will talk about who wants to do when, those sessions. But that's really what the meat of that session is going to be about, is talking about your project and kind of getting some next steps and answering any questions you have. And then that last session is where we can do updates on the project if something has happened since then, or think about larger next steps with this Center of Excellence on Addiction, Sheena's crew, who's on here. That will allow us to, if you guys want to do follow-up, things like that, we'll be able to schedule all that. Okay. Here's an example of what the case form looks like. This should be in your calendar invite, but it'll also be sent out in the recap emails. Pretty straightforward. We would like stuff in all these boxes if possible. It doesn't need to be a novel. Just something that we can react to. That's the main thing, and we can have questions and discussions around. And like it says there, the most important thing is bring us the questions that you have around QI. That's what the group's here for. This is the Echo team. You only have me, unfortunately. Mitra and Elizabeth are way better at this than I am. So sorry that you get the C team, it looks like, but they're available. If you can't get a hold of me for whatever reason, you can reach out to them if there's any issues with Zoom connecting, any things like that in between sessions. With that, I think that is it. I will stop share. And thanks, Katie. I appreciate that. And before we move to Mark, we're just going to break it up a little bit. We're going to go around and do some quick introductions. I know people have put their information in for CE credit in the chat, so it's kind of an introduction, but we're going to go around real quick and do some introductions. Dr. Hout, you unmuted. Is there a question or anything like that?
Just making sure I unmuted because I'm terrible at that.
Okay. Okay. See, I'm watching. Okay, I can see the Hollywood squares. So we're gonna go around real quick. So I'll just call you out. Let's start. First Hollywood square on my board is Joshua. Can you tell us who you are?
Yeah, hi, my name is Joshua Witt. I'm the operations case manager at Northwood Health Systems. I've been a part of project retention from what we started back earlier last year with Megan, Mega, and Sheena. And I'm looking forward to hearing the ideas and opinions of everybody else as well.
Thank you.
I'm a little right now, so that's why my voice is the way it is.
No worries at all. No worries. Let's see, Megan.
Hi, I'm Megan Toscano. I'm the project coordinator for the SOR team at WVU. I know pretty much everybody, I think, on here. I do a lot of the GIPRA stuff, a lot of admin for the grants. It's nice to see you all.
Thanks, Megan. Unmuted Dr. Hout. Yeah. Nice.
Sorry, I'm Mark Hout. I'm a faculty member here at WVU for, I don't know, ever now. And I head up the SOR, and Jay convinced me to do this, although he told me I was doing it in the spring, and this isn't spring, so.
No, it is snowing outside.
Yeah, that's a complete lie, but that's all right. Thanks, Dr. Hout. Let's go to Mega.
Hi, I'm Megha Gandhi. I am program coordinator for the SOR grant, and I do a lot of admin work and some of the finance. I help our team, Sheena especially, with the whole QI project. So if you guys need anything, please let me know.
Awesome. Thanks, Megha. Sheena.
Hi, everyone. I'm Sheena Sayers. I'm the program manager for the SOR grants. I think that's all.
Thank you. Stacy.
Hi, I'm Stacy Wanger, and I am the Assistant Director for the West Virginia Practice-Based Research Network, which works with a lot of the primary care sites around the state.
Thank you, Stacy. Let's see, Katie.
Hi, I am Katie Chasson Downs, lead clinician for addiction services here in the outpatient department at WVU Behavioral Medicine. And now that I've heard the label, I would really officially like a t-shirt that says Sheena's Crew. So if we could make that happen somehow, I would really appreciate that. And thank you guys so much. You know, it's late on a Monday evening and I really appreciate everybody making the time to be here.
Yes, definitely. Let's see, Tina.
Hi, I'm Tina Harper. I work with Northwood, and I am the Substance Abuse Treatment Program Manager for Northwood.
Awesome. Welcome, Tina. Tony.
Hi, everybody. I'm Tony D'Acchio. I am Associate Dean for Faculty Practice and Community Engagement at the School of Nursing and Clinical Associate Professor, and I work clinically in substance use disorder with the COAT team and work with them on several of the SOR projects, including QI. It's nice to meet you all.
Thank you, Tony. Christy.
Hi, I'm Christy Walker with Community Care West Virginia. I'm the Special Project Director over top of Addiction Recovery and Behavioral Health.
Nice to meet you, Christy. Thanks for being here. And last but not least, hopefully not on vacation still, Olivia.
No, not on vacation
Okay,
still.
okay.
Officially quarantining for 5 days.
Oh, as a COVID survivor, I understand.
I don't even have COVID. They just want me to quarantine because I have a sore throat. No fever, no anything else.
That's all I had.
But it's all right. I will take it. But I'm Olivia. I am the case manager in Morgantown, and I also work on the SOR grants and do a lot of the work on a lot of the QI projects.
Thank you, Olivia. Hopefully you're just, hopefully just 5 days. That's it. Thank you. Thank you, everybody. I know we've all probably crossed paths at various times. So thank you for doing that. Always good to get to know everybody. So with that, I'm going to turn it over to Dr. Hout. Let me share my screen and you can just let me know when you want me to advance the slides. Okay.
Yeah, I would go ahead and advance the slide, but thanks.
No problem. No problem.
So I have to say this with every talk. The most relevant kind of thing, the funding I get is I get funding from the SOR and DHHR and SAMHSA. These other fundings are not related to QI work. Next slide, please. So here's what we're going to talk about. We're going to talk about what QI is, what QI isn't, why it's important, some key things to doing QI, potential roadblocks, and then examples of actually doing QI in healthcare and then specifically in substance use treatment. Thank you, Jay. But I really want you not to anticipate me, please. All right. By the end of the session, you should know what QI is and what it's not, and know some examples of using this in substance use, but frankly, in healthcare and anything, actually. Next slide. So who might tell me what QI is? I'll call on somebody and it won't be somebody from our team.
QI can somewhat be summarized into retention services, keeping clients interacted, making sure that the quality of which we give as a treatment team or provider is at the utmost standards of practice.
Okay, good. Thank you. So anybody else have any other comments or thoughts? Christy, Tina?
So we have a pretty robust quality improvement department in our primary care sites, but we're really looking to integrate behavioral health and addiction recovery. So we want to figure out how to implement a lot of those strategies that we've been successful with in primary care into QI. But we look at it more as a way to improve our services, improve patient care, and patient engagement.
Great, thank you. Tina, anything to add?
For me, probably QI is the most important to keep a program fresh, to keep a program expanding and making sure we're meeting the needs of the clients in the community as we go along.
Excellent. Wow, great. All right, so thanks for joining today. It sounds like I really don't need to do too much with you guys, but Jay will be upset if I kind of back out too quick. So I guess we'll go through a few things here. Really good answers though. Next slide, please. So whenever anybody gives me a phrase or a word and asks me to say what it is, I get really, really concrete when I kind of go for a definition or an explanation. And so there are two words in quality improvement. One is quality and the other is improvement. And if you're very concrete, that means that you want to figure out how to improve quality. And whatever it is that you're in the business of doing is the quality that you want to improve. Now, some people put an E at the end, quality improvement, QIE, which includes evaluation, because that's an important piece of doing good QI work, which there has to be this evaluation component to what you're doing so that you can really know if what you're doing is improving or not. So quality improvement is trying to improve the quality of whatever the service is that you're providing. It's done in business all the time and has been applied to healthcare. The thing to keep in mind is that if you really want to know if what you're doing works, you have to have that evaluation component. But the other thing is that how you do this needs to be systematic and somewhat methodical and consistent, or you won't know if what you're doing is working or not. So if what you're doing is not done systematically or consistently, how can you tell if it's working? And then if how you evaluate it is not done systematically and methodologically, then how will you know what the outcome is? So there has to be system and method to whatever it is that you're doing with QI. To me, that's the easiest part to understand. I'm a researcher by nature and training. And so doing things systematically and with a method to it just comes natural to me when I want to try to answer a question. But we're going to talk about how this is not research in just a second. The other thing that's important is to keep in mind, you're not just trying to figure out why something doesn't work, but it's just as important to learn why something works and what the pieces of whatever you're providing are that do things well, because you want to replicate that and expand that also, not just correct things that aren't working. Keep in mind that if you do QI, you will always learn something. It may not be what you set out to learn or what you thought was going to happen, but you will always learn. And if you are always learning, you can almost guarantee that you'll improve whatever it is that you're working on, that you will have a positive impact on that. Next slide. So QI is not research. And this is really important. And, you know, the thing that really cued me into QI a while back was when somebody said, well, yeah, it's not research. You don't have to get an IRB to do that. Anybody know what an IRB is? Institutional Review Board. It's the group that you have to go to with a very systematic protocol before you do research with human subjects to get it approved. And I would describe it as painful dealing with an IRB. And if I never had to deal with an IRB again directly, my life would be so much better. I would just say that. No offense to the people on the IRB because they have a job to do, but they make your life painful. And when I heard QI is not research, you didn't have to go to the IRB, I thought, I'm just doing QI now. That'll be easy. But it just doesn't work that simply. But it is not research. They share certain things. And the best part about it is you don't have to go through the IRB. But there are things that are very consistent about QI and research. Next slide, please. So when you do research, you're always testing a hypothesis, an idea, or a theory, all right? So let's talk about COVID because we don't know what else to talk about anymore. So somebody tell me what the name of this new variant is.
Deltacron.
Deltacron.
Sounds like
I'm
a
done with
transformer.
COVID-cron. So we have this new variant. So somebody tell me something about this new variant that may be a little bit different than the Delta variant, the Omicron variant. What's different maybe about it than the Delta variant we had? Anybody heard anything?
So I just had it. So it's like less than two, like we got my whole family, we had like 20 people in our entire family friend group who got it within 48 hours during Christmas. It's much more highly transmissible. It moves faster, but the symptoms are much less severe if we were all vaccinated and boosted, so no problems.
So let me just say from the start, I hope you're okay and that everybody else in your family is okay. And if you are, I'm glad. So you just put an idea out there, which is that this is much more transmissible. And if you're vaccinated, it seems to result in less severe disease. Anybody heard why that might be? So one of the things that I've heard is that it doesn't go from the nasal cavity into the pulmonary or lung system. And so it seems to stay a little more local, and that may be it. But basically what we're doing here is we're coming up with a couple hypotheses, aren't we? Now your hypothesis, it comes from the study of 20 people, but that's not very systematic or controlled, but it is an idea. And people actually saw that and are now systematically testing out that idea, right? And that is how you develop a research project. But let's say instead of developing a research project, instead you want to apply knowledge about this to how your primary care practice is doing things during this Omicron surge, all right? And the idea is that it is more transmissible so that you are now only going to have patients wear N95 masks when they come into clinic. And all the providers and anybody in the building is also going to have an N95 mask on, all right? And so you're going to look to see if this doesn't cut the transmission rate. And the easiest way to do that would be kind of monitoring your own staff because you don't necessarily know what happens with all the patients, but you can monitor the patients too. So that is an idea that you have to specifically improve outcomes related to this. Now, you could turn that into a research project, but that is actually geared towards what? Improving outcomes for your practice. Now, to do that correctly, you would have to have some baseline information to tell if it works. So you'd have to measure something. So you'd have to measure your baseline rates of sick days out or number of staff who have COVID or who are symptomatic or have a positive test. And then you have to follow that over time and measure that over time, right? But you have to make sure that the intervention that you have is done systematically also. Does that make sense? Okay, so how long should you study this for, Christy? How long before you kind of stop and ask if wearing these N95 masks is really working and cutting the transmission rate amongst your staff?
In this current, I would say a month, you could probably tell
Yeah.
with Omicron.
So you wouldn't wait 6 months.
Not for, I mean, in a real world, yeah, you would have a longer study, but with a staff and in a healthcare, you just have to kind of, especially right now, we've stopped in-person meetings. We've done some of those things, and we'll see in a month if it helped at all.
Right. So that's a key point. Sometimes you have to do things very rapidly, and you have to take a look quickly and get some sense of that. And so you want to start looking at that data as quick as you can, and you want to incorporate new information as it comes out as quick as you can. And you may change things that you're doing as quick as you can based upon CDC recommendations or what somebody else learns. But it really wants to be a rapid kind of thing. When you're doing a research study, you develop the protocol, you implement it, and you stick with it. And this study may go for a year, 3 years. And you don't look at the data because it's all blinded. All right. And you don't have any idea. I have no idea how it's going because it's all blinded and controlled. QI is not that kind of attempt at kind of data understanding. It's real world, real life, rapid, changing, but changing based upon the data. Does that make sense? But if you change too many things at once, what happens? You don't know what works. So think about your own healthcare for just a second. When I see my doctors and they want to make a change with my medicines, and it is a list this long because I'm old now, so they want to make a change. I like it when they say, I think we're just going to change this to start with. And not change 3 things at once, because if it works or doesn't work, we have no idea what happened there. We're going to change this. We're going to see what happens for 2 weeks. If everything's okay, then we'll make this other change here. So they do it systematically, but rapidly. But if you change everything, you have no idea what's really working. So you have to have some method to what you're training as much as you're able to. Next slide. So who has done QI before?
We have here at Northwood Health Systems.
Okay. Tina?
Yeah, we have QI here at Northwood. Some of the other agencies I worked for in the past, I've been in an administrative position. We would do at least every 6 months, really take a look at the programs and services, see if we had increases, declines, talk to the clients, do surveys to just kind of keep track of that. And we do a lot of that here at Northwood too, doing surveys and seeing what getting the client input.
Okay. Somebody remind me to come back to what Tina said. All right. Christy, you mentioned you got a big QI group.
Yeah, we have, because we're HRSA funded, so we have to do all kinds of tracking and quality measures. But what we don't have, the quantitative versus the qualitative that would be more applicable to addiction recovery and behavioral health like to know if the therapy services we're providing, how they're helping, and versus the medical side, which is much more quantitative.
Okay. So I'm going to make an assumption based upon what Christy and Tina said. And so correct me if I'm wrong, because what we're going to talk about doing sounds a little bit different than what you guys described, which is you're gathering information and then you're deciding what to do. All right. And so what I want you to think about is a much more two-way street and flow of information that is always ongoing. All right. So every 6 months, you're going to check in and see how things are going. All right. And let's say things aren't going real good or they're going the same. What are you going to do? All right. And so once you have that information, you have to have a process to make a change to actually lead to improvement. And that should always be happening, even if you're staying the same and keeping the status quo, because there's always room for improvement. Next slide. Look at that. Always room for improvement. Maybe I've done this talk before or something, I don't know. Or maybe I just looked at it, maybe a little above. So it's an important thing to think about, which is improving outcomes. And whether it's for substance use or anything else in healthcare, improving outcomes is an important thing that you should always engage in. I try to do that with my clinical work at an individual level all the time. And when I was much younger, I would do a self-assessment at the end of every day and collate it sometimes at the end of the week and say, what could I have done better with this person? What could I have done differently with this person? What did I do well with that? So I had some kind of systematic way of understanding and improving things, so that I could get better at what I was doing. So there's always room for improvement, and you should always think about this as an ongoing process, but not a judgment, actually. And that's important. Who knows what M&M is? And I don't mean the candy. What's M&M stand for?
Oh, I'm going to take a shot. Is it morbidity and mortality?
It is.
Okay. Whew.
I think they changed the name recently, but I'm old, so I'm not changing the name. It's M&M conferences. And so in medicine, you do a lot of M&M, or you used to do a lot of M&M conferences, particularly around procedures. And so they get together and they talk about particularly bad outcomes. All right. What happened in this surgery that didn't go well with this patient that didn't survive? Now, the key to an M&M working is that whoever is presenting the case, they have to be able to present it in a way, and the people have to talk to them in a way that they don't feel attacked or like they did something wrong. All right, that this was a bad outcome. You have to be non-judgmental in looking at that so that you can improve what you do. But if you are defensive about that, then you're not going to listen to what those things are. In clinic or as a trainee, that's about getting supervision and guidance, and it's another level of that. You want to think about QI as kind of a group level attempt at improving the outcomes, using information from the people that you work with to get things going better, but you can't be defensive about it. So QI can improve outcomes for patients. It can improve efficiencies, lower costs. The thing I always used to look at is, how can I do my job more efficiently? How can I take care of what I need to take care of for this patient in less time? Because I could see more patients and help more people, or do other things like research, teaching, echoes, things like that. So improving efficiencies is important. Improving outcomes is important. Decreasing costs. And if things are going better, you're less likely to get burnt out. If you feel like you're getting nowhere and just that treadmill and not getting anywhere, leads to burnout. It also leads to a sense of accomplishment and pride when you see improvements with the outcomes that you're doing for patients. And that's not just for the provider, that's everybody in the clinic. That's everybody in the organization has a piece of this and has something to contribute. Next slide. All right. So these are the things that we came up with ourselves that we think are key to doing QI. That's not exactly right. Not that we came up with ourselves, but after studying this, being trained, working on this, these are some key things that we think are important. You have to specifically identify something that you're going to work on, and it has to be as specific as possible. Because if you make it global, it's hard to do. You can't give a Miss America answer. I want peace in the world. That's not going to happen in a QI project. It has to be something more specific. The simpler it is, the better chance you have of implementing something consistently and measuring the outcome. But it has to be related to whatever it is that you're going to do. Keep it as simple as possible, though. You have to be systematic and you have to be consistent. To be consistent, everybody on the team has to have buy-in. All right. So for folks in administrative positions, let's say that you're rolling out a new policy and you're presenting this to people. And this is back in the days when you did things in person and you present it and you see a bunch of eye rolls and head rolls. What's your response? This is not going to go well. Let me back up and let's try it again. All right. That buy-in is really, really important. So, and the buy-in is going to be for QI, everybody in the organization, above, below, and at the same level for the people that are doing this. Everybody's got a buy-in. Measurement before and after. You're not going to be able to tell if this is actually working unless you measure it and you can see the change. And as we'll talk about at the end, when you measure is actually important also. And then sustainability. What's sustainability mean? Jay, I'm going to pick on you. Use my ability to be concrete and define sustainability.
Being able to can you keep what you implemented going and be able to change it when you need to change it and keep, so it doesn't drop off. So you don't just do it for a month or two and then it drops off the table.
That's a terrible answer. I am seriously disappointed in you, Jay.
I'm not the
Sustainability
expert,
is the ability to sustain things. Come on. But what Jay says is accurate. So being able to keep things going into the future. So you need to think about sustainability with whatever idea that you're thinking about working on. Because I can tell you, if you don't have a way to make it sustainable, don't work on it. You're going to waste your time, effort, and everything because it's just pie in the sky. It has to be sustainable. You have to have a method to help it stay in process. If you come up with something that you can only do for a month, and it's never going to happen again, it's no good. Make sense? All right, Jay. All right. So this was one of those light bulb aha moments for me when I really understood QI and how it can work with something that is really pretty simple and basic. All right. So, one of the things that was hard for me to understand is early on in my career is why patients didn't do what doctors told them to do. I grew up in a family of doctors and, I got all my care when I was a kid and ever since then in academic medicine. And you just went and you went to the specialist. They told you what to do and you did what they said and it was all great. But following through on doctors' recommendations is complicated, particularly for a number of reasons. One is you may not be health literate. So I came from a very health literate family. And so some people really don't understand what it is that they're supposed to do. There's a whole host of reasons why somebody may not follow through. And so Medicare started looking at this idea that if you get readmitted to the hospital after you were just in the hospital in X amount of time, that means that whatever you guys did when they're in the hospital, you didn't do it well or right. We're not going to pay for a readmission, all right? That you've messed something up, because if they got discharged, they should be good. They shouldn't have this problem. And I was like, wow, that kind of makes sense. They're actually, for once, Medicare, the government is actually making just a little bit of sense here that readmission rates are a bad thing. Something's got to change this. All right. This is not a good thing. And then I heard one of the plans that someone had to address this. And I was like, well, that makes sense. Didn't make sense for me because I'm health literate and a little OCD. So I'd write everything down and double check and make sure I got everything I had to do and whatever. But they just did follow-up calls from nurses within X amount of time when you're discharged from the hospital. And they really made sure with patients that they understood exactly what they're supposed to do within 24 hours. And it really amazingly decreases readmissions for people who got home and really didn't know what to do. But when they're about to be discharged, they're nodding their head and their family's nodding their head and they just want to get out of there, right? It's amazing how much that decreased readmission rates. Discharge pharmacy. What's a discharge pharmacy? Anybody know?
Well, for us, it's a pharmacy specific for patients that are being discharged from inpatient services.
I loved how you defined that, Katie. That was awesome.
That was just for you, sir.
So what does that mean, actually? So somebody's leaving the hospital and what do? You give them their medicines that they're supposed to take as an outpatient, actually on the way out the door. They don't have to go on the way home. Somebody doesn't have to go back out and pick them up. Maybe they don't have the medicines. Maybe something happens. Wow, that's a really pretty basic idea too, isn't it? Guess what that does for readmission rates? It decreases them also. These are really pretty simple and basic things that people figured out could really improve outcomes, because there's a bunch of people who didn't understand what they were supposed to do, didn't understand their medicines, when to get them or how to get them. That's beyond some people. And if you take care of that piece for them, that improved outcomes. Did it completely eliminate hospital readmissions? No. And it never will, because actually the government makes us discharge people before they're ready. So they are part of that problem. But you kind of get the idea that these are actually pretty basic, simple things that you can do to change a process that may have a really good outcome. So how did they figure this out? Next slide. Actually, not next slide, go back. So how do you think somebody figured this out? A follow-up call within 24 hours, give them medicines on the way out the door. Who figured that out?
I would imagine it would be somebody working directly with the patient who has seen the patient a multitude of times, continuing to get readmitted. So they decided to come up with some kind of a strategy to ensure that they followed through with whatever continuity of care was offered.
So I bet that's a piece of it. Some of the people actually doing the care, inpatient as well as for the follow-up and outpatient. But you know who I bet also contributed something?
The patient.
The patient, or somebody who was a patient themselves, or had a family member who was a patient. So you get a whole group of people together and you start talking about these ideas, you're going to come up with some solutions. And you may be something that you're aware of, even though you're not a provider. It could be the registration clerk who says, you know what? My grandma just got discharged from the hospital and I was listening to the nurse talking to her and she didn't understand a word that nurse says. So I started listening for her so I could explain it to her. You know, who knows what it is? But it's usually a bunch of people getting together, talking about these things and just drilling down to it. Okay, next slide. Roadblocks. I've already said this. You got to have buy-in. The top person, the CEO, has to say you got to do this. They got to give you the resources to do this. Everybody who's going to implement it has to do that. Everybody has to feel a part of it. And the best way to make that stuff happen is have everybody involved in the brainstorming. So everybody owns a piece of it. You have to have the time to do this. Who has extra time right now? So you ask people that, everybody says nobody's got extra time. Jay asked me that. I said, I don't have any extra time. But I said, you know what? I'm going to be more efficient with what I do so I can figure out how to do this. But you say to people, this is time well spent because it's going to improve outcomes and improve efficiencies. Keep it simple, make it consistent. Next slide. All right. Anybody ever seen this slide before or something like it?
I believe there was something similar to this in the playbook.
There is. It should be that exactly.
Yeah.
Plan, do, study, act. Start anywhere you want, in a sense. It's circular and it's ongoing. It should never stop. What are we trying to do? How will we know if it results in an improvement? What are we going to make? What's the change going to be? How are we going to measure that outcome? Did that outcome work? Oh, is it still working? It didn't work. All right. So what are we going to try next? Oh, it did work, but we still have room for improvement. How can we add on to this? It's ongoing. And I will tell you, as somebody who does research, which usually often has stop and start points, and then you begin the next project based upon what you found, this is difficult. And I make mistakes with this ongoing aspect of this. Next slide. All right, this is the group that taught us how to do QI. We always like to shout out to NYTEX. And let's, you got the website there. They got a lot of great materials, but let's go on to this video because it's a great video that I love. And if you've seen it before, my apologies, but I always learn something every time I watch it. Here we go.
At NYTEX, one of the main things we do is to teach process improvement to behavioral health and human service professionals. Now, we've been known to explain our entire model of process improvement to folks over lunch. It's that simple. Here's how it works. Whenever you want to make a change or improve something in your organization, you start a change project. Now, every change project has one aim. Think of the aim as the target. It's that specific measurable goal you're trying to achieve. Now, to carry out a change project, you need people and some tools. On the people side, we emphasize three key roles. The executive sponsor, they're often a senior leader in the organization and they help remove barriers for the project. The change leader is the project owner and they lead and coordinate the change team, which is a group of staff members selected to work on the change project. Now, when it comes to process improvement tools, the NYTEX model focuses on 4 that we've found to be easy to learn and effective for most change projects. The walkthrough is a tool to help you experience a process just as your customer would. Flowcharting creates an actual picture of the process from beginning to end. The nominal group technique, this is a tool the change team uses to brainstorm ideas that will help achieve the aim of the change project. And the PDSA, which is an acronym for Plan, Do, Study, Act, is an efficient way to test changes. Rapid cycle testing, that simply allows the change team to try a change for a short period of time to see if it's an improvement. Finally, the NYTEX model has 3 rules for change leaders and their teams to follow when conducting a change project. One is to use existing resources. The goal is to achieve your change project aim using currently available staff and materials. 2 is to measure change. Simple measures are the lifeblood of successful change projects. So collect only the information you need to achieve your project aim. And 3 is to sustain the gains. Now, once you've achieved your aim and the change project ends, you must have a plan in place to monitor your measures and intervene if they creep back to unacceptable levels. That's it, the entire NYTEX model of process improvement. Now, to gain a deeper understanding of process improvement and the NYTEX approach, view our online course, Process Improvement 101, at nytex.net.
Okay.
How have I been a part of our NYTEX project for this long? And that's the first time I've seen that video, which is such a great explanation, except for that terrible looking hot dog. This is a terrible looking lunch, but everything else was great.
I don't know. I thought that hot dog looked pretty good since I'm not allowed to eat hot dogs anymore.
That was such a great explanation.
So hopefully some of those ideas and concepts were familiar to you from what we've talked about. All right. Buy-in, above, below, but you have to have somebody who's really going to own and drive this. And if everybody's trying to be the bus driver, you don't get anywhere, but somebody's really got to lead this. It doesn't mean that everybody else doesn't contribute, but you got to have that leader in there. Next slide.
At NYTEX.
Okay, so some of the things, again, that we've found useful, in particular, are the walkthrough. All right. It sounds kind of silly, but doing a walkthrough gives you a new set and a fresh set of eyes. All right. To understanding the problem. I really didn't understand that till I started working for a surgeon. And when he's doing a new procedure, he wants to do a walkthrough. Actually, I want him to do a walkthrough, particularly if he was going to be my surgeon. So you go through everything step by step and step. Everybody has their role and their place and what's happening. You go, oh, wait a minute, that's not working. So you try to identify it ahead of time and figure things out and get everybody comfortable with it. But it's also a great way to learn when you're going through a process about what works and what may not work and what may fall through for the clients. The nominal group technique, I've kind of renamed that in my own head. I call it throwing spaghetti at the wall and seeing what sticks. You guys ever do that with spaghetti to see if it's ready? Well, when I was younger and I lived in somebody else's house, I would do that all the time. I don't do it anymore in my own house because it sticks and it creates a mess, but whatever. So get everybody together and talk about it, come up with ideas, put it down, and then the group decide what it is you're going to do and how you're going to change. All right. And then chart it out so that you can do a walkthrough and figure it out and make sure that it works in real life. Everybody has a role. Everybody has an assignment. Everybody has to own those things. All right. You don't get in trouble for not doing it, but you problem solve why it's not happening. It's not a blame game, but it's an encouragement game. And you have to change as quickly as you can with this. Next slide.
Not to interrupt, but 2-minute warning.
I know. So real quick. So we did this for our substance use treatment program. We got everybody together. We got buy-in. We came up with an idea. Next slide. Everybody was kind of on board. Everybody thought this is great. We figured out what the next slide. The next problem was that we came up with is we thought our patients weren't showing up because they were afraid that they didn't know and understand what was going on. And it was lack of knowledge that made them hesitant, and they didn't know what to do in Zoom meetings. They didn't know expectations. They didn't know the rules. And so they were spending so much time trying to figure that out. And it caused so much distress and dismay that they just didn't stay in treatment. So we thought, let's not try to do all that and treat them at the same time, essentially. Let's come up with what we call an orientation group, put people in that, orient them, get them going. All right, let them learn the rules and then focus on the treatment. Remove as many barriers as we can to the treatment itself. Next slide. Keep going because we're out of time. Weekly meetings. When you're doing this, you got to keep up. Last slide. So I'm going to show you some new data. So look over on the left, and you can see that to begin with, we had a substantial improvement from our baseline, particularly that first month, where we had 65% retention. Up into March, our second month in, we had 86% retention. All right. That's a 20% improvement over time. That is amazing. All right. People engaged and sustained in treatment don't die. They get better. All those things. We were so impressed. We thought that was great. So we relooked at our data. If you look at this graph over here, and you'll notice that that initial bump was never achieved again. And actually in the last few months, we bumped back down to the average for what it is. And, you know, over time, to begin with, it was about 70% retention. And if you look over the last year, guess what our retention is? 70%. So what did we do wrong? I don't know. Well, I'll tell you one thing we didn't do is we didn't sustain our meetings and our focus and our look at this data. We got all caught up in how it was going and that it was going good, and we didn't keep looking at it. And that was the mistake that happened. And we didn't catch this until well over time. And something changed and happened. And now we're scrambling to figure out what it is. So the lesson learned is make sure that whatever change it is that you think you measured, make sure it's really there and it's consistent, and then that it's sustained. Do I think we really made that change to begin with? I think we did. But for something has changed, something is different now that has lowered us back to our typical baseline. Don't get me wrong, 70% retention is really pretty good, but when people are dying, 70% isn't good enough. So I'm going to pause because I have like no time left, right, Jay?
That is correct. That's okay. That's okay. Does anybody have any questions? We can take a couple minutes.
I actually have a question for Christy, if it's okay. Christy, just to prepare us for the future work that we're doing, does your quality department, is there a particular model that they use consistently for QI, or is it mainly post measurement, like look back? Do you like do PDSA or the FADE method, or is there a particular method that you guys use?
I don't think they have a specific method that they use, but we're constantly looking at like what's the next thing in rural healthcare and how we can position ourselves for it. So it's looking at like we look at our existing data, but then we make projections from it, and then we look at things that are more like national trends in order to try to predict like how we need to maneuver for bigger things. But then, you know, when we're looking at you know, our, like right now, social determinants of health is the big, you know, huge buzzword right now. But like how can we create the, as healthcare providers, we're being tasked to solve all the social problems and like, you know, build those social networks and everything else. How can we do that? So it's really trying to be proactive and use our data to position ourselves in that way. But I don't think they have a specific model. It just depends on what it is they're doing and what they're addressing and planning for.
Okay, thanks.
So what I'm going to say right off the bat is that I don't care what the model is, but you want to have a model, use it and stick with it in a process and a method. So who wants to tell me what I did when I presented the data there at the end where we didn't do well? Why would I do that?
To show things don't always work and you always have to reevaluate.
Yeah, you know, You got to be humble in this business, don't you? You really do. And you got to look at the data and you got to look at the information. It is what it is. And so even the teachers and trainers make mistakes and got to relearn things and redo things. So it's really an important thing to kind of keep in mind with this whole, what this whole thing is really all about is your willingness to look at what you're doing systematically so that you can improve the outcomes for people. And if you get too big for your own britches, you make mistakes and you don't help anybody. All right.
All right, with that being said, we'll close out for tonight. We appreciate you guys staying over a little bit. Our next session is going to be on the 24th. So be on the lookout for some reminder email on that and the connection information and everything like that. In the meantime, but before that session, if there's anything you need, please don't hesitate to reach out. And we look forward to seeing you next time.
Thank you, everybody. Have a good night. Stay safe.
Thanks, guys.
Thanks all.
See ya.